Bismillahirrahmanirrahim. Good day, everyone. It's my pleasure to be with you today to discuss tumor lysis syndrome, a potentially life-threatening metabolic emergency that remains highly relevant to both oncologists and nephrologists. Over the next few minutes, we'll explore the mechanism behind TLS, identify patients at highest risk, review current preventive strategies, and discuss evidence-based approaches to management, particularly when acute kidney injury develops. I'm Dr. Mahmoud Sheikh, nephrology consultant and World Kidney Academy educator. Thank you for your attention, and let's get started. Now, we have set the stage. Let's start by defining what tumor lysis syndrome actually is. At its core, TLS is a metabolic emergency that occurs when large number of tumor cells break down over a very short period of time, releasing their intracellular contents to bloodstream. That suddenly release leads to classic biochemical abnormalities we associate with TLS, like hyperkalemia, hyperphosphatemia, and hypocalcemia, and hyperuricemia. What makes TLS so important is that these lab abnormalities are not just numbers on a report. They can quickly translate into serious clinical consequences, include acute kidney injury, life-threatening arrhythmias and neurological complications, and even up to death. We most commonly see TLS in patients with hematologic malignancies, particularly during the first few days after treatment begins. However, it's important to remember that TLS can occasionally occur spontaneously even before therapy is initiated. The bottom line is that early recognition prevention are critical. Identifying high-risk patients before complication starts and develop remains the most effective way to improve outcomes in these patients. Now that we defined TLS, the next question is who is actually at risk? One of the most important things to understand is that TLS risk is not determined by cancer diagnosis alone. It really comes down to three factors: how fast that tumor is growing, how much disease is present, and how sensitive that tumor is to treatment. At the highest end of spectrum, we are highly proliferative. We have the highly proliferative malignancies such as Burkitt lymphomas, acute leukemias, and the high tumor burden and bulky aggressive lymphomas. These are the patients who can develop profound metabolic abnormalities within hours to days after therapy is initiated. Patients in the intermediate risk category will require close monitoring, particularly when additional risk factors such as elevated LDH and pre-existing kidney dysfunction or bulky disease is present. By contrast, most indolent hematologic malignancies and solid tumors carry relatively low risk of clinically significant TLS. It's also important to recognize that chemotherapy is no longer the only trigger. Today, highly effective therapies such as venetoclax and monoclonal antibodies and CAR T-cell therapy can produce rapid cell destruction and significantly increase TLS risk. And finally, TLS is not always treatment-related. Spontaneous TLS can happen before therapy is ever started, particularly in high proliferative hematological malignancies. The key takeaway again is simple: the most effective way to prevent, to identify the highly risk patients before treatment begins, because risk stratification drives everything that follows: monitoring, prophylaxis, and ultimately patients' outcomes. Now that we have identified who is at risk, let's take a closer look at how often TLS actually occurs and why it remains such as an important clinical problem. One thing that's important to appreciate is that the incidence of TLS varies considerably depending on the underlying malignancies and the population being studied. For example, in highly aggressive disease such as high-grade non-Hodgkin lymphomas, overall TLS rates can be remarkably high. However, not every patient who develop lab abnormalities will go on to develop clinically significant TLS. And that is important distinction. Lab TLS is considerably more common than clinical TLS. But once clinical TLS develops, the consequences can be substantial. In fact, as shown here, in hospital mortality rates may exceed 20%, highlighting that TLS is far more than laboratory abnormalities, potentially life-threatening oncologic malignancies, and lead to emergency situation. Another key observation is that acute kidney injury remains one of the most frequent and clinically relevant complications. As kidney function deteriorates, the body ability to clear potassium and phosphate uric acid declines, creating a vicious circle that can be accelerating the clinical consequences. The other important message from epidemiological studies is that risk is driven primarily by disease characteristics rather than patient demographics. Tumor burden, proliferative activity, and treatment responsiveness matter far more than age and sex and ethnicity. So the bottom line is that while clinical TLS may not be encountered every day, when it occurs, it carries significant morbidity and mortality, which is exactly why early identification prevention remains so crucial. To understand TLS, it's helpful to think of it as a massive intracellular dump in the bloodstream. When a large number of tumor cells break down over a short period of time, they release potassium phosphate nucleic acid, and faster than the body can eliminate them. The kidney suddenly becomes responsible for handling an overwhelming metabolic load. And that's where the menu of complications starts. Let's start with uric acid as nucleic acid are metabolized. Uric acid levels rise rapidly. Historically, uric acid crystal deposition within renal tubules was considered the primary cause of TLS-associated kidney injury, leading to tubular obstruction and decline in GFR. At the same time, large amounts of intracellular phosphate are released into the circulation. This phosphate binds calcium, producing hypocalcemia, while calcium phosphate complexes can deposit within the kidney and the other tissues, further worsening organ dysfunction. Hyperkalemia is often the most immediately life-threatening abnormalities because potassium is predominantly intracellular rapid cell lysis can result in sudden and substantial increase in serum potassium, placing patients at high risk of fetal cardiac arrhythmias. And finally, hypocalcemia develops largely as a consequence of phosphate excess. Patients may experience neuromuscular irritabilities, tetany, seizures, significant cardiac manifestations. The important concept that these abnormalities don't occur in isolation. They reinforce one another. As kidney function declines, potassium phosphate and uric acid accumulates even further, creating a vicious cycle that can really escalate into a medical emergency. So the bottom line of that TLS is essentially a metabolic storm driven by massive cell destruction, with the kidney sitting at the center of the process. Understanding the pathophysiology is important, but what really matters as a pesticide is recognizing TLS when it presents in front of you. One of the challenges is that early symptoms are often non-specific. Patients may initially complain fatigue, weakness, nausea, vomiting, abdominal discomfort, or simply feeling unwell. In a patient who recently started cancer therapy, these symptoms should never be missed too quickly. Most cases develop within the first 72 hours after treatment begins, which wise this period requires particularly close attention and monitoring. From nephrology standpoint, acute kidney injury is often one of the earliest and most clinically significant manifestations. Patients may develop oliguria, rising creatinine, volume overload, and symptoms of uremia as the metabolic burden overwhelms renal circulatory capacity. Many of physical findings are actually driven by underlying electrolyte abnormalities. Hypocalcemia may be present with muscular cramps, tetany, carbopetal spasm, classic stochastic control signs. In more severe cases, seizures can occur. At the same time, hypokalemia may be completely silent until significant ECG changes or life-threatening arrhythmias develop, which is why lab monitoring is often more informative than symptoms alone. The key point is that patients frequently deteriorate biochemically before they deteriorate clinically. By the time obvious symptoms appear, significant metabolic abnormalities may already be present. So whenever a high-risk patient develops new symptoms, shortly after treatment initiation, TLS should always be high on the differential diagnosis list because early recognition is often what prevents progression to severe kidney injury and other life-threatening complications. Once TLS is suspected, the next step is confirming the diagnosis and identifying patients before serious complications develop. One of the most important principles in TLS is that diagnosis should be proactive, not reactive. Waiting for symptoms to appear often means you are already behind. For that reason, close laboratory monitoring is absolutely essential in at-risk patients. Serial management, measurement, and potassium phosphate, calcium, uric acid, creatinine, and LDH allows you to detect metabolic abnormalities early, often before clinical deterioration becomes apparent. Continuous assessment of urine output is equally important since declining urine output may be one of the earliest signs of evolving kidney injury. To standardize diagnosis, we commonly use the Bishop classifications. Laboratory TLS is defined by the presence of at least two characteristic metabolic abnormalities occurring within a specific time. Window around treatment initiation, these include elevated uric acid, potassium, phosphate levels, or declining serum calcium. Clinical TLS represents the next level of severity. It occurs within lab TLS is accompanied by clinically significant consequences such as acute kidney injury, seizures, cardiac arrhythmias, or even sudden death. From nephrology perspective, the development of AKI is often the turning point that transforms biochemical disturbance into true medical emergency. It's also important to recognize the limitations of these criteria. They were developed primarily for treatment of related TLS and not fully capture spontaneous TLH, which can occur before therapy is ever initiated. So the takeaway is that TLS remains largely lab diagnosis, and the best outcomes occur when metabolic abnormalities are identified and treated before organ dysfunction start to develop. At this stage, it's worth emphasizing that one of the most effective treatments for tumor lysis syndrome is actually prevention. Once established TLS develops, management becomes significantly more complex. That's why identifying high-risk patients early and initiating prophylactic measures before treatment begins is so critical. The cornerstone of prevention is aggressive intravenous hydration. Adequate hydration helps maintain renal perfusion, increase urinary flow, enhance excretion of uric acid and phosphate, and reduce the likelihood of crystal precipitations within the renal tubules. The goal isn't simply to give fluids, it's to maintain effective urine output while carefully monitoring of signs of volume overload, particularly in patients with underlying cardiac or renal disease. Historically, urine alkalization was frequently used to increase uric acid solubility. However, modern practice has largely moved away from routine alkalization because potential benefits are often outweighed by risk of calcium phosphate precipitation within the tubules and the other tissues also. As a result, sodium bicarbonate is generally reserved for selected situations rather than used routinely in TLS prophylaxis. The other key preventive strategy is avoiding additional kidney injury. Patients at risk of TLS already have significant metabolic burden, so exposure to nephrotoxics such as non-steroidals, iodinated contrast, and other potentially nephrotoxic medications should be minimized whenever possible. The bottom line is that successful TLS prevention relies on maintaining renal perfusion, reducing uric acid burden, protecting the kidney from additional hits and insults. When these measures are implemented early, many cases of severe TLS can be prevented altogether. Along with hydration, the second major pillar of TLS prevention is controlling uric acid production and clearance. The three agents shown are all lower uric acid, but they do so in very different ways. And understanding those differences is essential in clinical practice. Let's start with allopurinol. Inhibits xanthine oxidase and prevents the formation of new uric acid. However, it's important to remember that it doesn't remove the formed one that already present in circulation. In other words, prevent uric acid from going up, but it doesn't bring it down again. Rasparex works very differently. It rapidly converts existing uric acid into allantoin, highly soluble compound that is easily excreted by the kidneys. Because of its rapid onset potent uric acid lowering effect, rasparex is generally preferred in high-risk patients with established TLS or those who already have significant hyperuricemia from the start. Of course, rasparex should be avoided in patients with G6PD deficiency because the high risk of severe hemolysis and methylglobinaemia. Febuxostat is another xanthine oxidase inhibitor and serves as alternative to allopurinol, particularly in patients who cannot tolerate allopurinol or when dose adjustment become very challenging. From a practical standpoint, the clinical question is not which drug lower uric acid best, but which drug is appropriate for patients sitting in front of you. For lower risk patients, allopurinol and febuxostat may be entirely adequate, but when uric acid is already elevated, the kidney function deterioration or TLS actively develop. Rasparex is usually the agent of choice because time becomes critical. The bottom line is simple: allopurinol and febuxostat prevent uric acid production, whereas rasparex rapidly eliminates existing uric acid, and understanding that distinction is fundamental to effective management of this entity. And despite optimal preventive strategies, some patients will still develop established TLS. When that happens, the focus shifts from prevention to aggressive management for metabolic complications and preservation of organ function. The first priority is intensive monitoring. The patients require close observation of urine output, volume stats, and cardiac rhythm, serial laboratory measurements because electrolyte abnormalities can develop very rapidly over a matter of hours. Hyperkalemia is often the most immediate dangerous complication. Management follows the standard principles of cardiac membrane stabilization, intracellular potassium shifting, and potassium removal. If hyperkalemia remains refractory or is associated with significant ECG changes, dialysis should not be delayed. Hyperphosphatemia can be particularly challenging because ongoing tumor breakdown continues to release large phosphate loads into the circulation. Aggressive hydration and phosphate binders are important, but severe cases often require extracorporeal clearance. Hypocalcemia requires a more cautious approach. While severe symptomatic hypocalcemia should be treated, routine calcium administration is generally avoided because it can promote calcium phosphate deposition within tissues and kidneys. From a nephrology standpoint, the most important decision is recognizing when renal replacement therapy is needed. Indications include refractory hyperkalemia, severe hypophosphatemia, symptomatic hypocalcemia, worsening acute kidney injury, and significant volume overload, or persistent oligoanuria. One important point is that dialysis in TLS is often initiated because of uncontrolled phosphate burden as much as potassium. In patients with an ongoing metabolic generation, continuous modalities may provide more sustained control and reduce rebound abnormalities. The bottom line is that successful TLS management requires rapid corrections of life-threatening electrolyte disturbances, meticulous supportive care, and timely initiation of dialysis whenever needed, when conservative measures are no longer sufficient for such patients. As we conclude, I'd like to leave you with one message. Tumor Lysis syndrome remains one of the few true oncology and nephrology emergencies where anticipation is far more important than reaction. The prognosis of TLS depends largely on how early it's recognized and how quickly appropriate preventive measures are implemented. Once severe metabolic abnormalities and derangement and organ dysfunction develop, morbidity and mortality rise substantially. The most feared complications include acute kidney injury, life-threatening cardiac arrhythmias, seizures, and severe cases, multi-organ failure, and death. From a nephrology perspective, it is often the central event that drives poor outcomes, making early identification of high-risk patients absolutely critical. It's also important to remember that TLS is not the only cause of hyperkalemia, hyperphosphatemia, and hyperuricemia. Conditions such as rhabdomyolysis, severe metabolic acidosis, hemolysis, vitamin D intoxication, and the other metabolic disorders may produce similar lab abnormalities and should be considered in your differential diagnosis. Ultimately, the greatest opportunity to improve outcomes lies not in treating established TLS, but in preventing it. Early risk stratification, aggressive monitoring, timely hydration, appropriate uric acid lowering therapy, and prompt nephrology involvement remains the cornerstone of successful management. If there is one takeaway from today's discussion, is this: the best treatment for tumor lysis syndrome is recognizing the patients who is about to develop it before it actually happens. Thank you so much for your attention. Hopefully, I covered the topic in a good way, and see you in the upcoming lectures, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.